Good evening, everybody who are watching this program from India, and good morning to those who are watching it from the United States. Welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Professor Baron Lonner from New York. Professor Lonner is a professor of orthopedic surgery at the Icahn School of Medicine in New York City. He's the chief of minimally invasive scoliosis surgery at the Mount Sinai Hospital. He attended the prestigious accelerated 6-year medical program at the Boston University, and he completed his general surgery internship at the Mount Sinai Hospital, and then his orthopedic training at the Montefiore Medical Center, and subsequently his scoliosis and spine surgery training at the Hospital for Special Surgery. Dr. Lonner has been professor of orthopedic surgery at the New York School of Medicine from 2010 until his move to the Beth Israel Hospital in 2013, and now is a full professor of orthopedic surgery at the Mount Sinai Hospital and School of Medicine. Dr. Lonner is a reviewer for 4 spine journals, and he's an associate editor on the editorial board of the Journal of Spinal Deformity. Dr. Lonner is a prior board member of the Scoliosis Research Society and longtime board member of the Setting Scoliosis Straight Foundation. Dr. Lonner has traveled extensively to developing countries in Africa, the Middle East, and the Caribbean, where he has performed operations on children with severe spinal deformities. He's a consultant for Debussynthesis and is one of the developers of the Expedium and the Expedium Plus spinal implant system used in treatment of spinal deformities. He's also a developer for the new spinal tethering system for non-fusion scoliosis correction with Zimmer Biomet Spine. Dr. Lonner is often considered the foremost authority for scoliosis correction using non-fusion technology. So today, it's my great honor to introduce you to Professor Baron Lonner. Over to you, Prof.
Thanks so much, Dr. Gopalan, and terrific for setting this up. And hello to my colleagues and trainees around the world. It's my pleasure to present to you on spinal tethering and growth modulation in the treatment of pediatric scoliosis. And I look forward to entertaining any questions that you may have later today. I have 2 relevant disclosures. One is that I'm one of the developers of the Tether system that we use, product of Zimmer Biomet, recently FDA approved in the United States. And I do consulting for them, as well as consulting for the ApiFix device, which is a posterior dynamic corrective procedure, which I will not discuss today, but happy to answer questions about. So, known to you all, the current treatment paradigm for pediatric scoliosis consists of observation for relatively mild curves, bracing for more moderate curvatures in the growing child, and then, of course, definitive spinal fusion at the time of the initial corrective surgery. There are growth-sparing options for early onset scoliosis, but these also end up in a definitive spinal fusion. So I'd argue that the pinnacle of our pyramid of priorities should be the preservation of motion. Obviously, correcting deformity and doing so in a way in which we minimize complications, preserving pulmonary function and life expectancy are very important. But for the adolescent patient, pulmonary function really is not a big concern except for the most severe curves. So what we want to strive to do, if possible, is to preserve flexibility, and that may result in better long-term outcomes potentially. So the standard of care for surgical correction of the patient with a deformed spine but with otherwise healthy motion segments is arthrodesis. And you can delay this fusion into adulthood if we can get the patients to skeletal maturity with a moderate curve. Perhaps we can just allow the natural history to play out and treat them later when they become symptomatic or if there's a further curve progression in the adult. And there's also a natural history of performing a fusion in the adolescent, and that is impacted by the LIV, or the lowest instrumented vertebra, and I'll show some data on that. The developments in the surgical treatment of scoliosis really has been a historical timeline of a century. And there have been largely evolutionary changes in our techniques, but some revolutionary changes as well, revolutionary impacts. For example, the first fusions performed in New York, actually by Hibbs and Albee at two separate institutions, were really something that hadn't been done before. And then Harrington, he introduced the metallic implant for the first time in the treatment of scoliosis, and this was considered highly controversial, an abomination, stated by a leading surgeon at the American Academy of Orthopaedic Surgery in 1958 in Chicago. I was in the audience when Professor Sook introduced thoracic pedicle screws in the pediatric patient at the Scoliosis Research Society at the Waldorf Astoria Hotel in New York. I remember standing up in the back of this dark room, and this professor from Seoul, South Korea, showing these cases, and there was really murmurs in the audience. It was so controversial, and now that's really just the standard of care. And then there was the introduction of growing rods, and then the magnetically controlled growth rods, really for the early onset scoliosis population. And now we have Tether, and then the posterior dynamic distraction as well coming in at the same time. So left to the far right, you see the Harrington rod on the far left, and the two arrows are showing what we were doing 20 years ago is anterior thoracoscopic fusion and instrumentation and fusion for thoracic curves. And we took that learning curve, and I'll show you some data on that as well, and applied that now to the use of a tether, which is a non-fusion approach. So arthrodesis is not physiologic. We've been doing it for 100 years, but it ought to be considered a salvage operation. Certainly whenever possible, we should try to preserve flexibility as we do for other areas in orthopedics. We rarely perform fusions of the hip or a knee nowadays. And we have some data showing that we can delay, if we have a skeletally mature adolescent, one could delay treatment later in the adult. But what happens there is a 5 times greater major complication rate if we delay and allow that to play out over the course of the patient's lifetime. They have much more pain, larger curves, and they have more extensive procedures done. And that's illustrated in this case example. We did a matched analysis and looked at how this curve might progress over the course of a lifetime. And so here, a 15-year-old on the left versus a 55-year-old, and you can see the differences: more levels fusion to the pelvis, more blood loss, and somewhat less correction of the deformity. And arthrodesis is permanent. You can't reverse it. And it may result in adjacent segment problems, as in this patient on the right that I revised down to the sacrum. And in particularly individuals who engage in recreational activities and sports that require a great deal of mobility, such as dance, gymnastics, swimming, that can be impacted by the fusion. So here we have a study in which we showed the impact of fusion 10 years following surgery in the adolescent patient. So based on the LIV. So if you fuse to L4, more than a quarter of the patients will have significant disc degeneration. This is at 10 years. So these are patients in their 20s. 10% for LIV of L3 and 7% for all comers in our study of about 100 patients with 10-year follow-up. And if you don't center that lowest instrumented vertebra right over the center of the sacrum, so it's off the midline a little bit, those patients have a much higher rate of disc degeneration. So a third of patients with a fusion to L2 or L3. And so sometimes we try to save a level to try to preserve more flexibility and have more motion segments available for the patient. But if you don't center that well, that's going to be associated with higher levels of disc degeneration. And this is a patient that I saw recently in my clinic. She's 12 years postoperative. She's 27 years of age. And she has already severe neck and low back pain. And that was her major complaint, just 12 years after surgery. So that's not the case for all patients, but it's what we can see. And perhaps that'll be less with a non-fusion alternative. Here's a patient, age 40, 25 years following surgery, the LIV of L2, and we had to extend her fusion down as well to the sacrum. And here, a patient with an LIV of a more caudal LIV, those patients are less likely to return to sport. So L2, L3, L4. So the lower you go, the less likely the patient's going to return to their activity and their sport. So the ultimate procedure is one that corrects deformity. It preserves pulmonary function, growth, and flexibility, and has low complication rate and high reliability. So maybe this is the ultimate procedure. This is my first tether case, and this is a young lady who I operated on 5 years ago. And here she is in the clinic at 3 weeks following surgery. And we did a double tether on her. So 3 weeks following surgery. And we're going to ask her to bend forward, flexion. And there she goes. You'd never do that with a fusion patient. She wouldn't be able to do that. Her back would be stiff and sore. So the recovery really seems to be a lot faster for these patients. And so the promise of vertebral body tethering is that it is motion sparing, and that data is being generated by a number of my colleagues, and it's associated with a shorter recovery and less blood loss, and it's reversible. Fusion remains an option for these patients. If long-term this doesn't work out, these patients can still undergo fusion, and perhaps the long-term follow-up will show less adjacent segment degeneration. So we have examples of motion sparing in all countries in the world. Hip and knee replacements are performed, and perhaps this is not a replacement. This is a growth sparing procedure. Perhaps we can apply this same to our patients with scoliosis. Here's our patient, one of my early patients, 5 weeks following surgery. So really quite dramatic. And then here's some data by Dr. Miyanji in Vancouver showing that flexibility is at least partially preserved. Now you can see if the patient bends to the right in this particular example, there's going to be a check rein. And so there'll be some decrease in the motion to the right, but to the left, it's intact, and in flexion, it's intact, and rotation as well. And that data, again, is being generated. And here we have just a collage of my patients and me in a pose there. Pre-mask, pre-COVID. But these are the types of patients we see who really seek out non-fusion alternatives. So what is the basic science premise behind this procedure? It's really about growth modulation. And we take advantage of remaining growth and the wedging and the anterior overgrowth that occurs as the etiology of this condition of idiopathic scoliosis, and we tether or provide a check on growth on the convexity and promote concave growth. And we have examples throughout orthopedics and other areas in which we take advantage of this asymmetrical growth and inducement of asymmetrical growth to have a gradual correction of deformity. And this takes advantage of the Heuter-Volkmann principle, in which asymmetric loading results in asymmetric growth and wedging of vertebra and the spinal curvature. And we sort of reverse that vicious cycle and make it a virtual cycle in which we reverse that and increase the concave growth by unloading the growth plates on the concave side. And the first attempts at this were done really with the use of staples. Historically, that hasn't worked out very well. It was tried in the 50s. And those staples would migrate, and then nitinol staples were developed, which kind of bit into the bone, and that was a bit more successful. But you'll see here's a case in which we did nitinol stapling, but the curve's very mild, relatively mild, and so these are barely surgical cases. And when you applied it to more severe curves, it didn't work very effectively. So the vertebral body tether is much more powerful. And a lot of the initial animal work came from people like Peter Newton and others. I'll show you some studies. So Peter placed a tether in a calf, and he had a control animal, he had single tethers, and then he put 2 cables to tether to have a more forceful tether. And what he did is he created scoliosis. And you can see the scoliosis is greater for the double tethers than it is for single tethers. And kyphosis was increased as well in these patients, which is important in this particular patient population because they lose kyphosis. They are hypokyphotic, and the trainees, you may see that in your in-training examinations, that idiopathic scoliosis has, again, a relative anterior overgrowth of the vertebral body, and that results in a relative lordosis or loss of kyphosis, and then there's a twisting that occurs, and that is thought to be part of the etiology, again, of this. So we're reversing that. And Dr. Newton also looked at the health of the disc within the tethered spine, how to control, and here the double tether, and water content is preserved. Proteoglycan synthesis, if anything, increased slightly on the compression and the distraction side in the tethers. Some changes in the collagen content of the disc, but the histological analysis showed just a narrowing of the disc, but actually preservation of the tissue type. And so we have also this study by Dr. Schwab and his team in a porcine model in which they created scoliosis and then they corrected it using a tether. And I like this study because it really shows very nicely. You create the tether, so where it says tether release there on the top row, that's the scoliosis being created. And then with application of a tether in this animal model, you see gradual correction of the curve over time. And also shows in the lower row that there's an improvement or an increase in kyphosis, which is one of the desired goals of our surgery for idiopathic scoliosis. And Schwab also showed an improvement in axial rotation. So not only do you correct the coronal plane, but also the axial plane, and of course the sagittal plane by increasing kyphosis, as I said. And you can see here vertebral wedging improves. So really an elegant study. I love this work. And here's the first clinical case reported. It was Dr. Lenke and Crawford wrote this up. He did one case, and this was probably, it's reported 10 years ago, so probably about 15 years ago. And I asked Larry if he had follow-up on this patient, but he wasn't able to get back to me on that. In our country, in the United States, FDA approval for the device was received in August of 2019. So those of us who were performing this procedure, at least in the United States, were doing this so-called off-label, but now we've got the benefit of regulatory approval. And this is the new device that we use. We place the screws, we place the tether, and then we tension the tether using these tools that were developed specifically for this procedure. And it's done through these small portals and incisions, minimal incisions. We learned a lot about how to do these minimally invasive procedures through my thoracoscopic fusion work 20 and 25 years ago. But again, the exposure is quite elegant and relatively bloodless. You dissect the pleura, we place our screws just anterior to the rib head and right across, and we get a bicortical fixation here as shown. We line the screws up, and we want to put them in a harmonious kind of smooth arc so that they line up very nicely in the sagittal plane, as you see there, and we can create a nice kyphosis. And so we place the screws, we tension the device, and you can see with that, at a year, you can see a wedged vertebra can actually square off and become more rectangular, as shown here at the apex of the deformity. So that's the proof of concept right there. And you can see a nice preservation of kyphosis in this patient at 3.5 years. There's a learning curve, and we showed the learning curve, as did Peter Newton, for thoracoscopic fusion. And I think the learning curve will perhaps be a little less here, but it's not a procedure that can be taken lightly, and there is work that has to be done to be trained properly for it. But I think that can be done, and so it's going to be in the hands, I believe, of centers where a significant volume can be performed. And again, we reported on thoracoscopic fusion 14 years ago now, so I went through the learning curve in my practice. And I think that we'll train more and more surgeons to do these procedures in fellowship. And we had these very nice short fusions, and now we take away the metal rod and we add a polyethylene teraphate tether instead of the rod, and we don't remove the discs. And we can do these through small incisions. And we had similar approach for thoracolumbar curves in which we did these fusions. And again, we're using the same or similar incisions, perhaps smaller than what we used to do. I think our incisions back then, 20 years ago and up to recently, were larger. Now we're doing these through much smaller incisions. So this is a patient, a 10-year-old girl. This is a little bit large for a curve, but she's young. So we felt that we had, because her curve was very flexible and because she had significant remaining growth, that we might be successful here. And I say might because, that's the uncertainty of what this procedure brings. There's a little less certainty and reliability of this compared to a fusion where we can put the vertebra where we want, we lock them in and fuse. And so that's a very predictable operation. And that's what we tell the families. We're not 100% certain. And I'll show you some data of the uncertainty. So here at first direct in the upper right-hand corner, you can see it doesn't look very good. So we've got substantial correction, but the patient's leaning to the right. There's a lumbar curve, but that's because the patient is sore. It's at 4 or 6 weeks after surgery. They're kind of favoring that right-sided incision. And we saw the same thing with thoracoscopic fusion work that we did and thoracolumbar curves. The patient leans to the side. Families are nervous about it. And then when they come back for follow-up, they stand upright because they're not favoring the incision any longer. And you can see over time, she corrected and then she overcorrected just a little bit below in the lower caudal segments, but not enough to warrant a reoperation. And she's done really well now to skeletal maturity. And here's a double tether we did. You can see not quite the same correction as you would get with a fusion, but flexibility is maintained, so perhaps desirable. The first clinical series was reported by Samdani and Betts, and you can see in 11 patients, the preoperative curve 43 degrees down to almost 22 degrees at first direct, and then at follow-up, the curve improves further. And then they presented a number of years ago to skeletal maturity. And again, similar findings, correction, and that improves further over time. And I think what happens later is as some of the cords break, they may get back to that first direct 20-degree or so curvature in some cases. And here, Peter Newton reporting in a Journal of Bone and Joint Surgery as well, improvement from 50 degrees. And sort of at 1 year, it's at its lowest, and there's a little bit of attrition back up to near 30 degrees. And that's probably because there's some breakage of the cords over time. I would argue, based on the disc degeneration data and the mobility data that we have, that these patients, the thoracolumbar curve is probably the ideal candidate for this procedure, although most of the reports have been in thoracic curves, and we're going to report on thoracolumbar as well. Peter Newton has sort of put a pause on sort of the enthusiasm for the procedure, and he reported two cohorts of fusion versus tethering. The thing is that it wasn't a matched analysis. He was presenting those patients sequentially that he performed tether on. They were younger patients with a lot more growth remaining, and it was his early learning curve in creating the indications. He had 23 VBT patients versus 26 spinal fusion patients, and there was a 30% revision rate for the tethers versus none in the fusion. And 13% of his tether patients underwent fusion, and additional 3 were indicated for it. I think that what happened in this study is Peter was operating on much younger children with open triradiate cartilage. There's a little more unpredictability there. They can overcorrect, and that was his point. So I think if we operate on slightly more mature patients, we're going to have perhaps different outcomes. I looked at, and we're going to publish this, I looked at my first 199 cases, complications within 90 days, and we had 6 major complications in nearly 200 patients, including a chylothorax, 2 patients with hemothorax, and 1 lumbar radiculopathy that required me to revise a lumbar screw that was in the foramen. Here you can see the hemothorax in the right chest here in this patient that developed 1.5 months post-operative, and we had to drain that, and she's done well since. Here's a patient, we put a screw a little bit posterior, into the foramen. This patient was symptomatic, so we had to revise that. She's done well now out 3 years. And I have 2 patients in which the proximal screw plowed a little and pulled back. One of them has really done very, very well and did not require anything. This patient, we offered revision of that screw. The family declined, and he didn't have quite the correction we would have liked to have seen. And sometimes we'll have a minor overcorrection of the curve, but the overall alignment holds very nicely. And so I really think this is not a complication, but it's part of the concept of this procedure. And here, this patient was overcorrecting. You can see at 1 year post-op, we were recommending a revision to either remove or loosen the tether. But she's a high-level swimmer, butterfly swimmer. It puts a lot of mileage on the spine, and or kilometers on the spine. And you can see she broke her tether, and that was fortuitous because we didn't have to go in and revise. She did it for us, and she'll probably break the one below as well, which will make, have her line up very nicely then. She's a really high-level butterfly swimmer, and a fusion would have really impacted her ability, especially if fusing down to L3. I think it would have had probably some impact on her swimming. So we did a matched analysis of patients, and I presented this at the recent virtual Scoliosis Research Society meeting. It was my own patients. We matched by Lenke curve type, major curve within 8 degrees, and age as well as kyphosis. And so we had 25 matched pairs. So the age is the same, 21, the gender distribution was the same. Most of these were Lenke 1 or Lenke 5 curve types. And so we look at the major curve. The major curve corrected similarly for both patients, first direct and 2 year, with similar numbers. In this matched analysis, the minor curve or the secondary curve was similar, although a bit less in the VBT, but they were statistically similar. And the reason I think that the curves were smaller in the VBT group is because we instrumented some of those minor curves. And kyphosis was improved in the tether patients to a greater extent than what we were able to achieve in the fusion patients. And here's some examples. Fusions are a bit longer and maybe a bit straighter, but actually in our analysis, they were similar. Here's a thoracolumbar curve, again, a little longer for the fusion patients, similar correction. And double curve here. I would say that better correction for the fusion, but here you are fused to L3 versus tethered. And we'll have to see how these play out. If we could do a long-term analysis on these patients, I think would be quite powerful. The inclinometer improvements were similar as well for both groups. And so operative time, similar number of levels instrumented, actually in our series was similar, and blood loss was quite significantly more for the posterior fusion patients. There were 2 major complications in the fusion. One was a misplaced screw that required a reoperation and 1 infection. And we had 3 cord breakages in our VBT patients with no significant regional loss of correction, just focal segmental loss of correction. And those patients have not, at this time point, required reoperation. And the SRS questionnaire scores for the various domains were similar for both, not statistically different. And here's just another case. You can see quite a nice alignment with our double tether on the left, and nice alignment with a fusion, but at the expense of motion. And perhaps there's a role for both fusion and non-fusion. Some patients present with very severe, very large thoracic curves. And I think in those patients, it would be irresponsible to even attempt to tether. But here we can tether the thoracolumbar component of her curve. She overcorrected a little bit there, but she's doing very well. And here's, again, my first patient. She's now 5 years post-operative and highly active and doing quite well out to 5 years. So I think there's a lot of promise for this procedure. We've got a lot to learn. We achieved the triple aim of correction, growth, and flexibility. And the long-term results are going to be the key here as to how these patients do over time. The posterior dynamic distraction, the ApiFix device, that's shown there in the right corner. And that's another interesting development and something that we're going to be looking at as well. We've started to do those cases. And then the question is there a role for some of these procedures for the more skeletally mature? And my group and I have been exploring that with more mature patients than for what this is indicated. So the key is that we don't burn any bridges, and patients get to, and their families have the choice, and there's a shared decision-making paradigm that allows them to look at what is known and what isn't known, and the potential drawbacks of one procedure versus the other in making their decision. So I thank you for your attention. I hope you found this informative and interesting, and I'm happy to entertain questions.
Thank you, Professor. Fantastic lecture, and really happy to see the kind of cutting edge work that you're doing at Mount Sinai. Just a few questions. Now, do you do the procedure in a lateral position with CD navigation?
Yes, so we do the procedure in the lateral decubitus position. We sometimes will do double curves, so we'll do one side and then we'll place our chest tube and flip them over and do the other side. So we'll change their position. And we use fluoroscopy for the procedure. We're not using spinal navigation at this time, but I think in the future we'll develop navigation techniques as well.
And what about those cases where you were using a combination of fusion versus and non-fusion? In those patients, do you think a prone position would be good?
So what we do for those patients, and I have quite a number now, we're doing more and more of those for the benefit of a stable correction of a large thoracic curve, but the mobility that we can maintain with the lumbar curve. So we have to do that in two different positions, at least at the current time. We're doing prone positioning for the posterior fusion, and then we place the patient in lateral decubitus afterwards. So it makes for a long day, but you know, we've been finding the patients doing quite well with that. It's just a bit of a longer recovery, you know, more like 3 months versus 6 weeks for the tether.
And how do you, when you do the thoracoscopy, sometimes the diaphragm keeps coming up, right? So do you put a stitch and bring it down?
That's a great question. Well, what we do is we actually, what I do is I use a mini thoracotomy. So it's about a 4 centimeter incision. And through that incision, we'll put a retractor where we'll hold the diaphragm down. You can do a stitch, but we find that the retractor just holds it more reliably. If we do it through pure thoracoscopic portals, then you can use a small Kittner, which is a little ball-shaped kind of a probe, and we can push the diaphragm away with that. But I find this mini thoracotomy allows us a much more efficient operation, and very small incisions. And most of it is done through a portal and the use of the scope, but the one mini thoracotomy affords a little bit more efficiency for the surgery.
And regarding the segmental vessels, do you cauterize them? And is there a risk for a spinal cord ischemia when you do that?
Great question as well. You know, we've done, before this, my whole career really of 25 years, I've taken thousands of segmental vessels, and there have been some studies before from the Minneapolis group, Dr. Winter and Lonstein, where segmental vessels have been taken and sacrificed, and there hasn't been an impact on the spinal cord. But certainly there's a theoretical potential for a problem. We have not routinely clamped the vessel and then done the spinal cord monitoring to assess the health of it. I think if there's a patient with congenital abnormalities, they may also have aberrant vasculature. And certainly if there's a question, one can do vascular studies preoperatively, and one could try to preserve the segmental vessels, but it's difficult because the screw, it goes right in the center of the vertebral body where the segmental lies. So we haven't done that routinely.
And whenever you try to get the screws in, do you try to get a bicortical purchase, and do you use hydroxyapatite coated screws?
Yes, so the screws are titanium and coated with hydroxyapatite. So, and we let our patients back to their activity by 6 weeks, and I haven't seen any loosen. So I think just the coating with hydroxyapatite increases the insertional torque. So you have a better bite to the screw, if you will. And then over time, there's some better growth of bone around the screw, and I think they fix very firmly. Having gone back to revise my own cases or other surgeons' cases, I tried to loosen one of the screws and take it out, and it's quite firmly fixed. So they really have an excellent fixation to the vertebra.
Thank you, Professor, for that. The other question is, do you get a Sanders classification of the wrist x-rays before you do that? And does it have a correlation? For example, if it's a Sanders grade 2 with respect to curve progression?
Yes, and we're really having to, now that we have FDA approval, we have started a registry with the Setting Scoliosis Straight Foundation and the Harm Study Group, my colleagues from around the United States and outside of the United States as well, where we are going to collect lots of data, including the Sanders score and RISR, but we do collect a left-hand x-ray in all the patients, and if they're a Sanders 2, they're prior to peak height velocity, there may be a higher risk in that patient for overcorrection. And so we're trying to time the procedure just right. So maybe 3 and 4s are better to avoid that. But if you have a large curve, Sanders 2, it may be right. But getting the tensioning of the cord correct by the segment, by the level, do we overcorrect or do we tension more, I should say, at the I'm sorry about that. Do we tension more at the, I'd like to unplug that. Virtual meetings, sorry about that. But do we tension more at the apex of the deformity? I think the answer is yes, because we want that growth modulation to occur there, and a little less tensioning at the terminal ends, particularly for patients that have significant growth remaining. So Sanders, curve magnitude, flexibility of the curve, the timing of the procedure, the tensioning of the cord, all of these parameters, we're going to go into some machine learning eventually, and we'll be able to have more predictive value to our decisions and be able to kind of guide ourselves and others as to the best way to go about this in terms of timing and technique.
Prof, thank you for that. Just one last question before we wind up.
Yes.
What are your contraindications? Do you think there are any contraindications for this particular procedure?
Yes. So I think large curves, so the FDA approval is for curves up to 65 degrees. And from it's either 30 or 35 degrees. I think that doing a 30-degree curve or 35-degree curve is probably not a good idea as well, because they'll almost certainly overcorrect depending on the timing. So if they're a little more mature, that might be appropriate. But a larger curve, more than 65 or 70 degrees. And having said that, I've done larger curves, but the larger, more rigid curves are not going to tend to do very well. Patients with significant kyphosis, so more than 50 degrees of kyphosis, they're going to become hyperkyphotic. Those won't do well either. Those are the main contraindications. And of course, now the standard is to not operate on skeletally mature patients. Perhaps there's a role in some capacity for that, and time will tell with data how that might play out, and whether there's the possibility of remodeling a vertebra even in the skeletally mature patient. So those are maybe more experimental areas to pursue.
Thank you, Professor. I think that's all the questions that we have for this session. Thank you for joining. Fantastic lecture, really cutting edge work. And this is going to benefit a lot of people as well as patients all over the world. Thank you very much for joining in, Prof.
Well, it's been my pleasure. It's great to be with you. Take care.
Thank you very much.
Bye-bye.